Federal Workforce Fallout is sponsored by Prince George's Community College.
You're watching Federal Workforce Fallout, where each week we break down the impacts to our neighbors in the federal workforce. I'm Larry Miller. This week, thanks to support from the Pulitzer Center, we're looking at what's changed a year after USAID was shut down by the Trump administration. I spent 2 weeks traveling throughout South Africa and Botswana investigating the Trump administration's America First Global Health Strategy, PEPFAR, and how organizations that relied on USAID support are doing 1 year later. I sat down with Dr. Jennifer Cate. She's the Senior Vice President and Director of the Global and Public Health Policy Program at KFF. She has decades of experience in policy analysis and research focused on the United States global health role and on HIV. Dr. Cate, thank you for being here.
Thank you.
I want to kind of get your sort of big picture view of PEPFAR. This is a program that you know a lot about, you've worked with extensively, and some would characterize it now as being sort of in a very delicate state where you don't know whether month to month this program that has been life-saving, transformative for nations really around the world is on the precipice of potentially no longer existing.
Yeah, so stepping back, PEPFAR it's kind of an amazing story. I've been working on global HIV issues for a very long time, predating when there was a PEPFAR. Hard to even imagine at the time that there would be such a program. And when it was announced in 2003 by George W. Bush, president at the time, it was unexpected that the U.S. president, a Republican president, would say, we're going to launch this unprecedented multi-billion-dollar program to try to address this burgeoning health crisis in Africa. And what happened, it was a bit of an experiment. It worked. Many lives were saved. And in fact, the estimate is about 26 million lives have been saved so far. And the program was scaled up and truly transformed much of the delivery system in Africa and other places, as well as I mentioned, saving many lives. What's happened, and that program has enjoyed incredible bipartisan support. So when other things in Washington were kind of falling apart, or partisan bickering was happening, PEPFAR always seemed to kind of stand outside that. That began to change in the last few years. So there was increasing partisanship on everything, including PEPFAR. And by the time President Trump started his second term, the combination of that plus this new administration's desire to reimagine or change, or in some might say take apart the foreign assistance structure, meant that PEPFAR and all other global health programs were fundamentally changed. They were halted, they were disrupted, many of the projects were canceled, some of the work was stopped temporarily, some permanently. And the PEPFAR we have today, while it's still probably it is the cornerstone of what the U.S. does on global health, is not what we had a year ago.
And a lot of things have been sort of born from PEPFAR on the research front, on the delivery of care front. Yep. It seems like PEPFAR has allowed us to learn a lot about HIV and then ways to fight it and address it as well.
Yeah, I mean, PEPFAR, because of the expansive response that the U.S. launched and brought other countries along with it, and the U.S. is also the leading researcher on HIV research, and the U.S. was implementing massive programs throughout the world in over 70 countries at one point with HIV programs. There was a lot to learn. When it was scaled up and started, they weren't sure that we could do this, that the U.S. government could do this. Virtually no one had antiretroviral therapy in sub-Saharan Africa at the time. Maybe 50,000 people. Now that we know that the majority of people who need antiretroviral therapy in the world have access to it, it's an incredible accomplishment. And through that, we learned, the community of people doing public health, global health research learned a lot about how you bring programs to the field in hard-hit areas and how you scale them up.
The administration has sort of been addressing global health differently with its America First Global Health Strategy. Their allegation is that this program and others have been saddled with fraud, waste, and that they're trying to get rid of the abuse as well, as they've termed it. Based on what you've studied, what you know about PEPFAR, has this program been the victim of sort of fraud, waste, and abuse?
I've not seen evidence of that. I think it is the case that what's happened over time is what started as an emergency program in 2003 and was meant to stave off a major crisis on the continent of Africa, became part of like the way many countries were responding to their healthcare system. The U.S. was supporting commodities and supply chains and clinics and laboratories for HIV, but it, of course, could benefit many other areas, and there's evidence that it has. And at some point, maybe in the last 5 years or longer, there have been increasing discussions about, well, what's the end game here? How long will the U.S. be doing this? And I think good questions. Should the U.S. do this in perpetuity? I mean, at what point do country governments take on more of their own response? So that was a really important discussion happening in Washington and elsewhere. Also, what became clear is that some of the money, and quite a lot of it, wasn't being spent on direct services. It was being spent on things that supported direct services. So TA, other kinds of training, ways to support, the development of health systems. Some of those are quite important activities, but they're not the same as providing medications or being a healthcare worker. So what happened with the Trump administration coming in is they looked at all that other stuff. They called it waste, fraud, and abuse. I think it was just a different view about where we should put limited dollars. But it wasn't the case that it was being used in fraudulent ways or being misdirected. There's always examples of that in government programs, but it was, and not anymore in PEPFAR than anything else, it was really more about, should we be spending all this money on services that maybe aren't going directly to clients, but are helping to bolster the things around them.
Mm-hmm. And now the way that the administration is moving forward with these sort of memorandums of understanding is that a lot of these countries that in fact either have agreed to accept PEPFAR funding will do so understanding that they will have to take on more of the financial burden of these programs. Does this make sense to you in terms of sort of providing the support, but also providing an off-ramp as well for the U.S.?
Yeah, and one of the critiques that had come up before the second Trump administration was, what is being asked of countries? The U.S. has been quite generous giving funding to countries. What's being asked of countries? And should there be some kind of co-investment requirement, which frankly is done by many other global health institutions. So that was a discussion underway. And so I think in and of itself, these new agreements are direct agreements with the U.S. government and countries, which are relatively new. And the idea there is like, let's agree to the terms, and we can talk more about that. But part of the terms are we, the U.S. government, is what the government's saying, are going to scale down our support over a period of time, and your requirement is to scale it up and put more of your own domestic resources into this program and into supporting the health of your own citizens. So I think that's the arrangement, and I think that makes sense, especially if a goal is to transition these programs to more country ownership financially and programmatically.
There have been some critiques, though, of these agreements as they've been termed right now. For countries that have accepted them, what is noted is that it now requires these countries to provide the U.S. with an increased amount of data and access to information that we have never had sort of been privy to before. Additionally, for countries that have been offered these contracts and have declined, there are allegations and reporting that suggest that the U.S. has asked in some cases for mineral rights associated with getting PEPFAR funding. There fears like from the State Department to these countries where they are doing the negotiations for this money, that it is heavily involved in sort of the politicking, and that in some cases people have described it as almost extortion in some cases.
Yeah, so these are new. It's a new approach for the U.S. to be doing these direct agreements with country governments. The U.S. did work with country governments, but not in this way. And so if you look at the available memorandums of understanding that are out there, there's a subset that one could read. They do ask for data. They do ask for data, reporting, and for in some cases access to specimens around outbreaks and other.
Have you seen anything like that before?
No, not with the U.S. for these kinds of agreements. I think what's different and what's, the comparison is not an easy one to make. Prior to this, the U.S. was running PEPFAR, right? And the U.S. would say, we have a PEPFAR data system. All the partners that we're funding have to report data about PEPFAR into our system. And that was what the standard was. What they're now saying is, we're going to give you money, governments. You need to give us data so we understand what's happening, but we want the data from your system. And that's really different. And there's also, some of the data requirements are quite broad. So that it's raised this question of, is this overreach? Is it requiring too much of private data? Now, the US government has said we're not asking for any personal identification information. We just want data for tracking and accountability purposes. There's been some pushback by advocates saying, this is too much. And in fact, some of the original drafts called for data sharing for, way beyond the period of the agreement. And I think those have mostly been adjusted. But beyond that, as you know, there has been reporting about at least one of the agreements, including access to mineral rights. And that has gotten a lot of pushback, even though I believe that country is moving towards, is still going forward. But I think the issues that it's raised up is this is becoming very transactional and political, whereas before it's not that politics were never involved, but it really was just about health. And it was just about the US supporting HIV services in these countries. And this is a real shift, a shift in approach, a shift in goals, a shift in the relationship.
Let's sort of think about the data set. As as you're a researcher, you understand the importance of data. They're asking for a broad amount of data. Is that fair, and does it give them reliable information about how their money is being used in this country and for the services that they've requested the money for?
Yeah, I think the answer is we don't know. And I think there's been issues raised that moving this way, even though I think there's general support, moving to country ownership, moving to country systems needs to happen. There's going to be this transition period. We're in it now, where are we just going to stop the PEPFAR reporting, which has been incredibly rich and vital, and is already not as robust as it has been, which we can talk about, and move to, what are we going to move to? So in that period, are we going to be in a situation where we can't monitor, we can't track, and then if things go off, don't continue in a positive direction, if some of the health outcomes maybe are starting to be compromised, we may not know until it's too late. So I think those are really valid concerns. And even the US government will say we have to figure out how to best collect and report data now that we're moving to this new model. I don't think it's been figured out.
How does that complicate the response with limited data, where you may not have the sort of complete, thorough picture that you've had in the past? I'd imagine that impacts your ability to make sure, one, care is being distributed, and two, also to track the disease and infections.
Definitely. I mean, there's an accountability issue because Congress is still going to want to say, we're appropriating these funds. We want to know how they're being used and what the impacts are. So there's that issue. But really, just from a health perspective, we're talking about, at least with HIV, we're talking about an infectious disease. And it's not the kind of thing you can look back on in a couple of years and say, oh, there was a trend that we missed because we didn't have the data. Now we're in a much worse situation. You want to be able to detect challenges as soon as you can. And PEPFAR has been fairly unique in having like quarterly data available that we understand probably won't be anymore. So it is a trade-off. It's what I think the US government is making, which is we are moving to this new way of doing business. We're having to give up some of that direct visibility. That could prove ultimately have a real negative impact on health outcomes, at least in a transition period.
We know that countries like South Africa, for instance, one where the disease is highly prevalent, hasn't been offered an agreement.
Yeah.
There are some tensions between the two nations at this point that are certainly complicating things. How concerned are you about sort of the state between the two countries and the implications that this could have on access to care and infection rates?
So the South Africa case is an interesting one. The U.S., this administration, I should say the administration, has real political disagreements with South Africa, with the government. Not about PEPFAR, not about HIV per se, but about broader politics. And it's a really good example how that broader political clash has interrupted what had been a very long-term relationship between the two countries on HIV. And so right now there's an executive order that the president had issued last year saying we're not going to support South Africa in foreign assistance and other areas. And they're not supporting them now. They're not seeking to do an MOU with South Africa. Now, on the one hand, South Africa happens to be, has some of the best HIV response, in some areas in the world, some of the leading researchers. It's not one of the poorest countries. It definitely has more resources than some other countries. So in many ways, it is positioned differently and has more ability to take on and do its own work, which it had been doing. On the other hand, it still hasn't solved the HIV crisis, and there's still a lot of people living with HIV in South Africa, and as you mentioned, high prevalence. So this rupture could really complicate things. And even if, under the best of circumstances, just having a big departure like that, when you've had this long-term relationship, creates real challenges. And again, it's an infectious disease. So at the end of the day, who's going to suffer? It's likely going to be people with HIV and those at risk for HIV.
Yeah, no doubt. And we will have more of our conversation coming up after this. Welcome back to Federal Workforce Fallout. PEPFAR, which stands for the U.S. President's Emergency Plan for AIDS Relief, started in 2003, and it's creating and has been credited with saving more than 26 million lives, getting support and treatment and resources to people in countries that need it most. But the Trump administration has made changes to the program, namely the amount of money partner nations receive, and that could have serious consequences. We know that because of recent changes that there have been disruptions to the workforce.
Yeah.
Can you talk to us a little bit about the sort of impact that has had? I'd imagine that too is an issue when we think about infection rates and the progression of the disease.
Yeah. So one of the things PEPFAR has also done is invested in healthcare workers. In many of the countries in which it worked, there were not a lot of healthcare workers, and so one of its big investments has been that, and that has paid dividends. I mean, those healthcare workers delivered HIV care and treatment and prevention services, and also other services. A doctor can do more than just treat one kind of disease, right? So it had these incredible, important effects and benefits for countries. With last year, with all of the disruptions, many of those healthcare workers lost their jobs temporarily or in some cases permanently. And what the new plan is that the U.S. Has under the America First Global Health Strategy is to fund the current level of workers for this year, but then beyond that, start to ratchet down that support. So their argument is, countries should be paying for this. The U.S. government shouldn't be paying for the healthcare workforce of other countries. And you can see that has an important aspect to it. On the other, if there are gaps or abrupt reductions, that's the front line. That's the front line of who has been responding to outbreaks, the front line of who has been reaching those most at risk, who are hard to reach, and getting care and services to people who do have HIV. So, time will tell, but the loss of the workforce is one of the stories here that is, probably one that's going to be felt for a while.
You've acknowledged that the administration has a clear point of view as it relates to changing the model in terms of what this looks like long term. Is it the issue that they are interested in sort of changing the program, or is it the way in which it has happened?
I think it is, if I had to pick, I would say it's more the way. The disruptions of last year, of 2025, the stop work order that was put in place by the Trump administration, which basically said, stop giving all services at all across the board. Eventually, some of the PEPFAR services were resumed, but not all of them. Stop paying people until we, have a review, and then canceling many of the awards, it was very disruptive, and caused a lot of, a very abrupt, unexpected shifts, and closing down a major federal agency that was the main agency that ran many of these programs. I mean, that was an upheaval that wasn't anticipated, and it happened. So that created, going into this new strategy, I don't think anyone had done a clear accounting of what was left and what the damage was or what was still standing. And so the new strategy, I think, has a lot of really important ideas in it, and many ideas that predate this administration that have been talked about. But I think it's hard to separate that from what had happened. So that's probably the biggest challenge. The second, though, is, and this would be the case with any transition plan, the speed and the way in which it's done matter. So if it is done too quickly, that can present real risks. If countries are not able to take on the responsibility that the U.S. wants them to, what happens then? If it means more spread of HIV, is that the result that the U.S. wants? That seems to go against the ultimate goal here. So the pace matters. The requirement of co-investment matters. If countries can't spend that, if they just can't, for a variety of reasons, what happens then? and how the U.S. Coordinates and works with countries, some of the transactional nature. Hopefully that's truly a partnership, but it is a transaction. So the way matters, and I think it's really about is the transition going to be done too quickly, too abruptly, and is it going to be harmful to health outcomes, or can that be managed? And we just don't know.
Do we know anything about sort of where infections stand right now? Are we seeing any sort of changes to the number of people that are getting infected, those that are being treated as a result of these changes implemented by the Trump administration?
It's a great question because part of the challenge of all the changes from last year is the data systems were at first taken down, and then only last week were some new data put out. But also a lot of the ways in which data would have been provided and collected, those services had to be taken down as well, or were canceled, or people lost their positions. So the ability to monitor and track and report was really compromised. Just last week, last Friday, at the end of the day, the Trump administration released the first data on PEPFAR from 2025. What they released was 1 quarter of data from the last quarter, which is July to September 2025, which is in the period of disruption. And all of us who do this work, us included, we're trying to analyze the data, but I can give you some top lines.
Yes, please.
There's some mixed results, some potential signs of continued progress, and some areas where there might be some concerns. Now, there are limitations. We only have 1 quarter of data, so we can only compare that to some prior year quarters. But what we see, the number of people on antiretroviral treatment seems to have remained steady between that last quarter and the year before quarter. That's good. However, the number of people newly put on ARVs, so that's a really important access measure. How many people with HIV are getting onto ARVs went down. The number of people tested for HIV went down. The number of new HIV positives went down. Did the positives go down because there's less HIV infection or because of less testing? We don't know. The number of PrEP users went down significantly, pre-exposure prophylaxis, which is a tremendous biomedical accomplishment where you can take an HIV treatment before becoming infected and virtually prevent most infections, all infections, by some of the newer interventions. Those went down. So it's mixed. There was some resiliency there and some steady numbers, but other things went down.
Considering all the factors that you've listed that have shown decreases, that certainly does compromise the positive, does it not?
It could. I mean, it's true. I mean, one of the things this administration has really prioritized frontline service delivery. So getting medications to people, getting needed care, life-saving treatment. They have moved away from the other things PEPFAR used to do, which was more of the surrounding support services, prevention, wide-ranging prevention services, other than PrEP, which they've put limits on, but are still very much supporting, because they don't see those as the most essential, critical services. We know from years of what we've seen in this country, in the U.S. as well as everywhere else, that you can't combat HIV successfully just through medication alone. It's much more complicated than that. People have a lot of complexities in their lives. They face multiple challenges. Where they live matters, what access they have matters, and can be really difficult. So these other services were put in place over time to facilitate access and to facilitate knowledge. I'll give you an example. One of the programs that the U.S. launched maybe a decade ago was called the DREAMS program, and it was designed to provide at-risk adolescent girls and young women in multiple African countries with a whole range of prevention services to help keep them in school, to help give them access to financial support and protection. The things that keep girls and young women able to participate in school and other parts of their lives without having to compromise, look for other places for work and potentially become infected with HIV. That program has virtually gone away because they're just a different priority. So they're moving from those kinds of programs, so we see that in the data. What we don't know yet is what might be the impact on HIV outcomes, and that's going to take a little bit of time still to see.
And if you had to hypothesize in terms of what this would look like, what would you?
If I had to hypothesize, it's hard to see how everything that happened last year and these ongoing changes are not going to negatively impact HIV outcomes. Will it be a catastrophe? I'm not going to say that. There were some predictions that it would be, but it's hard to see how it won't have a negative impact. Maybe there'll be a rebound in a positive way over time, but one HIV infection that shouldn't have occurred, that occurred because of it, is really a failure of what we've all been trying to do.
If you had to characterize, based on what you have seen thus far, the administration's America First global health strategy, does what you're seeing with PEPFAR give you hope for the future about what the administration is trying to do on a global front as it relates specifically to global health?
I think what the new strategy is really, PEPFAR is kind of the center of the new strategy because it is the biggest program area of global health for the U.S. It is the place where the U.S. had the biggest investment. So it is going to, it should drive forward whatever is being done. And this administration, at least the people in the State Department, have talked very, positively about PEPFAR as well and wanting to support it. Scaling up lenacapavir, a new twice-yearly PrEP injection that prevents almost all new HIV infections through a new partnership with the Global Fund to get len to people, so through PEPFAR. So there's a lot of good that this administration is seeing with PEPFAR, and I think this idea that the U.S. government can develop real partnerships and transition plans with countries to build up their own health systems is a good one. So I think that is the positive here, and could lead to like long-term permanent change in countries. It's just in this transition period, there's a lot of risk. So I think it's a TBD at this point.
Our thanks to Dr. Jennifer Cates for her time. Also, be sure to look out for and check out Aid Interrupted. It begins streaming Wednesday on WUSA 9. This is my investigative series looking at the fallout associated with USAID. Of course, you can count on WUSA 9 to stay on top of the reductions to the federal workforce, those affected, and what it means for our communities. In the meantime, scan the QR code on your screen. It will take you to a special section of federal workforce fallout and our coverage of this story on our website on WUSA9.com. Thanks for being here. We appreciate you as always, and we'll see you again soon. Take care.
You've learned a lot in life, on the job, in the military, raising a family. At Prince George's Community College, that experience can count as college credit. You could earn up to 15 college credits towards your degree just for what you already know. Eligible Prince George's County grads can even attend tuition-free with the Promise Scholarship. So what's your game plan? Turn your journey into a degree at Prince George's Community College.